In this video, we will discuss nephrotic syndrome. Nephrotic syndrome, it is a group of disease characterized by massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria, and hypercoagulability. All these 6 features will be the characteristic features of nephrotic syndrome. There will be no hematuria in nephrotic syndrome. This is the main difference between nephrotic and nephritic syndrome. There will be no hematuria in nephrotic syndrome. So, massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria, and hypercoagulability are the features of nephrotic syndrome. The causes of nephrotic syndrome. First type is primary glomerulonephritis. Secondary causes will be systemic diseases. Third one will be systemic infections. Fourth one will be hypersensitivity reactions. Fifth will be malignancy. Sixth, pregnancy. Seventh, circulatory disturbances. And eighth, hereditary diseases. So, there are 8 causes for nephrotic syndrome. Primary glomerulonephritis, systemic diseases, systemic infections, hypersensitivity reactions, malignancies, pregnancy, circulatory disturbances, and hereditary diseases. Coming to the primary glomerulonephritis, the most common primary glomerulonephritis cause is in children is minimal change disease, and membranous glomerulonephritis is the most common in adults. Next, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, not nephritis, sclerosis, FSGS, focal and diffuse proliferative glomerulonephritis, IgA nephropathy or Berger, BERGER, Berger disease. So, total 6 conditions under the primary glomerulonephritis that will show nephrotic syndrome. One is minimal change disease, second is membranous glomerulonephritis, third is membranoproliferative glomerulonephritis, fourth is focal and diffuse proliferative glomerulonephritis, fifth is FSGS, not GN, focal segmental glomerulosclerosis, and sixth one Berger disease or IgA nephropathy. Coming to the systemic diseases, all the systemic diseases like diabetes mellitus, systemic lupus erythematosus, and amyloidosis will end up in nephrotic syndrome. Coming to the systemic infections, viral infections because of the hepatitis B, hepatitis C, and HIV, or bacterial infections because of bacterial endocarditis or syphilis or leprosy, and falciparum malaria and filariasis will also result in nephrotic syndrome. Coming to the hypersensitivity reactions because of the drugs like heavy metal compounds like gold, mercury, penicillamine, trimethadione, tolbutamide, heroin addiction, and snake bite, IV poisoning, and bee stings will result in nephrotic syndrome. Coming to the malignancies, all the carcinomas, myelomas, and Hodgkin's disease can present with nephrotic syndrome. In pregnancy, toxemia of pregnancy may present with nephrotic syndrome. Circulatory disturbances, remember, renal vein thrombosis and constrictive pericarditis. These two will end up in nephrotic syndrome. And last but not the least, hereditary diseases. There are three diseases. One is Alport syndrome, second is Fabry's disease, and third one is Neil-Patella syndrome. These hereditary diseases will also show nephrotic syndrome. Earlier, there will be edema in nephrotic syndrome. You can observe the edema in nephritic syndrome also, but the edema in nephrotic syndrome is due to fall in the colloid osmotic pressure, consequent upon the hypoalbuminemia, and it is not due to sodium and water retention. In nephritic syndrome, the edema is because of sodium and water retention, but as in nephrotic syndrome, it is because of the colloid osmotic pressure. Coming to the hyperlipidemia, liver in response to the heavy urinary protein loss, as there is proteinuria, heavy proteinuria, selective proteinuria, there will be increased synthesis of lipoproteins, and there will be increased blood levels of these total lipids, cholesterol, triglycerides, VLDL and LDL. But if you see the report, there will be decrease in the HDL. So except the HDL, everything, all other lipoproteins will be raised. Only HDL will be decreased, and it results in hyperlipidemia, which is a feature of nephrotic syndrome. As there are more and more lipids produced, there will be passage of lipids in the urine, resulting in lipiduria. And there will be hypercoagulability because of the increased urinary loss of the antithrombin 3, hypofibrinogenemia, hyper. All other are decreased, but fibrinogen is increased. Hyperfibrinogenemia. Emia means blood. Fibrinogen levels increased in the blood. From increased synthesis in liver, altered levels of protein C and protein S will result in renal vein thrombosis. As I said earlier, in the causes of nephrotic syndrome, hemolytic disturbances, circulatory disturbances, the renal vein thrombosis is one of the cause. So hypercoagulability will result in renal vein thrombosis. So edema is because of the colloid osmotic pressure and not due to sodium and water retention as in nephrotic syndrome. And there will be hyperlipidemia and hyper excretion of the lipids in the urine, that is lipiduria, hypercoagulability resulting in renal vein thrombosis. There will be decreased levels of HDL and there will be only increase in fibrinogen levels in the blood. Out of the 6 conditions of nephrotic syndrome, first one is proteinuria. There will be proteinuria in both nephritic syndrome and nephrotic syndrome, but in nephritic syndrome it is non-selective proteinuria, but in this nephrotic syndrome it is selective proteinuria. Selective proteinuria means loss of low molecular weight proteins more than 3 grams per 24 hours. Okay. Selective loss of low molecular weight proteins more than 3 grams in 24 hours. And there will be hypoalbuminemia because as there is more and more albumin going out of the body through urine, there will be decreased levels in the blood. Hypoalbuminemia is produced primary consequent to urinary loss of albumin, and it is partly due to increased renal catabolism of albumin. Plasma albumin levels are 1 to 3 gram per deciliter. There will be albumin to globulin ratio reversal of albumin to globulin ratio. Coming to the immunoglobulins, the immunoglobulins will be raised, rendering these patients more vulnerable to infection. That is, immunoglobulins will be decreased, not increased. Decreased immunoglobulins resulting in infections with many bacterial. Out of them, the most common will be pneumococcus, and it will result in spontaneous bacterial peritonitis. So spontaneous bacterial peritonitis is the most common infection seen in nephrotic syndrome because of the decreased immunoglobulins. And the causative organism is pneumococcus, followed by E. coli. Coming to the antithrombin is decreased, rendering these patients more vulnerable to the thrombotic and thromboembolic complications. And these increased coagulability or hypercoagulability will predispose to renal venous thrombosis or renal vein thrombosis. Now coming to the transferrin levels, the transferrin levels will be decreased, resulting in microcytic hypochromic anemia. So in nephrotic syndrome, you will observe microcytic hypochromic anemia because of the transferrin levels decreased. Coming to the cholecalciferol binding protein, it is also decreased, thereby resulting in hypocalcemia. Thyroxine binding globulin will be decreased, causing the decreased thyroxine levels. Ceruloplasmin also decreased. The only protein that is increased in nephrotic syndrome is fibrinogen levels. So fibrinogen levels are increased due to increased hepatic synthesis. Except the fibrinogen, all are decreased. It can be albumin, it can be immunoglobulins, it can be antithrombin, transferrin, cholecalciferol binding protein, thyroxine binding protein, ceruloplasmin, everything. Only fibrinogen levels are increased, remaining are decreased in nephrotic syndrome. Causes of nephrotic syndrome, we have discussed that the first causes will be primary glomerulonephritis, second will be systemic diseases, third will be systemic infections, fourth will be toxemia of pregnancy, circulatory disturbances and malignancies, and hereditary nephritis. So in the primary glomerulonephritis, the nephritis that are involved in nephrotic syndrome are, first one is minimal change disease, second is membranous glomerulonephritis, third one is membranoproliferative glomerulonephritis, fourth one is focal glomerulonephritis, and fifth one focal segmental glomerulosclerosis, and last but not the least IgA nephropathy or Burger's disease. In the minimal change disease, the features will be of the nephrotic syndrome with highly selective proteinuria, and the pathogenesis is because of reduction of the normal negative charge on the GBM, glomerular basement membrane, and the mechanism is mostly cell mediated. And on light microscopy, as there is minimal change, there will be no variation in the glomeruli. The glomeruli will be normal. There will be lipid vacuolation in the tubules. This is only observed under the light microscopy. Coming to electron microscopy, there will be no deposits in minimal change disease. So nil deposit disease, but there is, on electron microscopy you can observe the loss of food processes. So loss of food process is the minimal change that is being observed under the electron microscopy in minimal change disease. And coming to the immunofluorescence microscopy, it will be negative as there are no deposits. Nil deposit disease is minimal change disease. Coming to membranous glomerulonephritis, this will present with all the features of nephrotic syndrome, and the pathogenesis lying behind this membranous glomerulonephritis is local immunocomplex disease. Local immune complex disease. On light microscopy, there will be diffuse thickening of the capillary walls. So when compared to minimal change disease, here the glomerular capillary walls, diffuse thickening will be there. Diffuse thickening of the capillary walls, and there will be deposits, subepithelial deposits present, and they are shown under the electron microscopy as spikes. Coming to the immunofluorescence microscopy, there will be granular IgG deposits and C3 deposits that can be seen under the immunofluorescence microscopy. Coming to the membranoproliferative glomerulonephritis, this also presents with the features of nephrotic syndrome. It is three types: MPGN1, MPGN2, and MPGN3. MPGN type 1 pathogenesis is immune complex disease, whereas MPGN type 2 is because of the dense deposit. So it is also called as dense deposit disease. Minimal change disease is nil deposit disease, whereas MPGN type 2 is DDD, dense deposit disease, and it is because of the activation of alternate pathway. Coming to type 3 MPGN, it is rare with systemic diseases and drugs. On light microscopy, there will be lobular proliferation of the mesangial cells. There will be lobular proliferation of the mesangial cells, and there will be increased mesangial matrix. And if you observe, there will be double contour of the glomerular basement membrane, which is a characteristic feature of MPGN. So double contour of glomerular basement membrane is seen in membranoproliferative glomerulonephritis. So as they are MPGN type 1, type 2, type 3, the deposits on electron microscopy will be, in type 1 it is subendothelial. Remember, there will be no deposits, only loss of food processes in minimal change disease, and there are spikes because of the subepithelial deposits in membranous glomerulonephritis. But whereas in membranoproliferative glomerulonephritis type 1, it is subendothelial. Type 2 is dense intramembranous deposits. Type 3 is both subendothelial and subepithelial deposits. So they are coming in the order. Loss of food processes, first one, no deposits. Second, subepithelial. Third one, that is MPGN. Type 1 is subendothelial. Type 2 is dense intramembranous. Type 3 is both subendothelial and subepithelial. And in membranous glomerulonephritis and glomerulonephritis, it is IgG deposits and C3 deposits. But in type 2, along with the C3, and there will be propyridine deposits also. In type 3 MPGN, C3, IgG and IgM deposits are also seen under the immunofluorescent microscopy. Coming to focal glomerulonephritis, the clinical features will be variable. It may present with hematuria. All the causes of in nephrotic syndrome, there will be no hematuria. But in focal glomerulonephritis, hematuria is common. And the pathogenesis is variable. Possibly the cause may be immune complex disease. Coming to light microscopy, focal and segmental proliferation. So the name itself is saying focal. So focal and segmental proliferation. And there will be mesangial deposits in the focal glomerulonephritis seen under the electron microscopy. The deposits will be IgA and IgG, C3 and fibrin, or IgA, C3 and fibrin. Okay, focal glomerulonephritis, hematuria common, and there will be focal and segmental proliferation. There will be mesangial deposits. These are the features of focal glomerulonephritis. Coming to the thing that is different, focal segmental glomerulosclerosis. It is not FSGN, it is FSGS. It will present with the features of nephrotic syndrome. The pathogenesis is, most of the times it is idiopathic or the cause is unknown, and it can be present because of superimposed primary glomerular diseases, or it can be because of the secondary type. So 3, idiopathic. Second, pathogenesis may be with superimposed primary glomerular disease, and the third one, secondary type. Here also on light microscopy, you will observe the name itself is saying focal and segmental sclerosis will be there, and hyalinosis also will be seen. Here also, just like minimal change disease, you will observe loss of food processes, but there are electron dense deposits in the regions of sclerosis and hyalinosis. So on electron microscopy, in minimal change, there will be no deposits and loss of food processes will be there. But in focal segmental glomerulosclerosis, there will be loss of food processes and there will be electron dense deposits in the regions of the sclerosis and hyalinosis. The deposits for focal segmental glomerulosclerosis will be IgM type. In focal glomerulonephritis, IgA. In focal segmental glomerulosclerosis, it is IgM and C3. And last, IgA nephropathy. This is also called as Berger disease. There will be classical history of painless hematuria and pain in the loin. Okay, painless hematuria. Don't confuse. When you are passing the blood, there will be no pain, but there may be pain in the loin region. Okay, so painless hematuria and loin pain. Most of them will confuse with this history. If there is abdominal mass, painless hematuria and loin pain, then it is because of the RCC, renal cell carcinoma. But if there is no abdominal mass, but there is loin pain and painless hematuria, then you can confirm it as IgA nephropathy clinically. So there will be recurrent hematuria. Proteinuria will be mild. Massive proteinuria will be there in nephrotic syndrome and selective proteinuria will be there. But in IgA nephropathy, the proteinuria will be very mild. The cause is unknown. Possibly alternate pathway disease is suspected as the pathogenesis for IgA nephropathy. Coming to the light microscopy, it is variable and it will commonly present like focal proliferative glomerulonephritis. As we are saying focal, so there will be mesangial electron dense deposits. So focal glomerulonephritis and IgA nephropathy, there will be mesangial electron dense deposits. And on immunofluorescence microscopy, it is IgG and C3. Earlier, the basic difference between nephrotic syndrome and nephritic syndrome will be there will be a history of hematuria in nephritic syndrome, but there will not be any history of hematuria in nephrotic syndrome. And the most common cause for nephrotic syndrome will be membranous glomerulonephritis in adults, and in children it is also the minimal change disease, also called as lipoid nephrosis. Whereas in nephritic syndrome, the most common cause for nephritic syndrome will be RPGN, rapidly progressive glomerulonephritis. These most common conditions you must know. In nephrotic, in children, it is minimal change disease, and in adults, it is membranous glomerulonephritis, or you can remember like MCD in children and MGN in adults nephrotic syndrome, and RPGN in nephritic syndrome. And in both nephritic syndrome and nephrotic syndrome, there will be edema. The edema is because of the decreased colloid osmotic pressure, or because of the colloid osmotic pressure, and it is because of the hypoalbuminemia in nephrotic syndrome, whereas the cause for edema will be sodium and water retention in nephritic syndrome. Of you, this question can be asked for 6 marks question, and or it can be asked for 3 marks question, or in the practical viva, if there is a case of urinary examination with proteins and blood passed in the urine, definitely they will ask you, the externals will ask you the differences between a nephritic syndrome and nephrotic syndrome. So we will discuss this nephritic syndrome and nephrotic syndrome in a simple and easy way. Okay, proteinuria is present in both nephritic and nephrotic syndrome, but it is mild in nephritic and massive or heavy in nephrotic syndrome. It is mild means less than 3 grams in 24 hours in nephritic syndrome, more than 3 grams in 24 hours in nephrotic syndrome. Hypoalbuminemia is uncommon in nephritic syndrome, but it is very common and it will be presented in nephrotic syndrome. Edema is present in both nephritic and nephrotic syndrome, but the edema will be mild in nephrotic syndrome, and marked and general and peripheral edema will be seen in nephrotic syndrome. So the edema is because of sodium and water retention in nephritic syndrome. It is because of hypoalbuminemia or decreased colloid osmotic pressure in nephrotic syndrome. That is the mechanism. Coming to hematuria, there will be hematuria present in nephritic syndrome. Microscopically, you can observe it. So microscopic hematuria is present in nephritic syndrome, whereas it is absent in nephrotic syndrome. Coming to hypertension, hypertension is present in both nephritic or nephrotic syndrome, but the nephrotic syndrome, the hypertension will be seen in the more advanced cases. Coming to the hyperlipidemia, it is not seen in nephritic syndrome. It is the feature of nephrotic syndrome. As there is no hyperlipidemia, there will not be any lipiduria in nephritic syndrome. As there is lipidemia, hyperlipidemia, there will be lipiduria in nephrotic syndrome. Coming to oliguria, oliguria is decreased urinary volume in 24 hours, less than 500. Okay, so it is present in nephritic syndrome. It will be presented in advanced stages in nephrotic syndrome. Hypercoagulability is absent in nephritic syndrome, and hypercoagulability is present in nephrotic syndrome. So you can write all the features, 6 features of nephrotic syndrome. They are present in the nephritic syndrome. Proteinuria, mild and non-selective in nephritic syndrome. Massive and severe selective proteinuria in nephrotic syndrome. Edema, as I said, both the present, mild and marked, and conditions. Hematuria not there, present. Hypertension present in advanced stages in nephrotic. Oliguria is also present in advanced stages. Hyperlipidemia, lipiduria, and hypercoagulability are present in nephrotic syndrome. So this is a basic difference between nephritic syndrome and nephrotic syndrome.